Hello everyone, my name is Sara Monti. I'm a rheumatologist from Italy. It is my great pleasure to welcome you all to this last webinar of a series we had as a Vasculitis Awareness Month, organized between ERN-RITA in collaboration with EUVAS, the European Vasculitis Society. Today we're talking about pregnancy and vasculitis, and I'll hand it over to Maria Cid, who is chairing the session and presenting you all the speakers. Very welcome to all of you. Thank you.
Good morning. My name is Maria Cid. I am a senior consultant at the Department of Autoimmune Disease in Hospital Clinic Barcelona, Spain, professor at the University of Barcelona, and group leader at the Research Institute EDVAPS, and I will be chairing this session. After a brief but very important introduction by Heather Tam, who is a patient research partner, mother of 2 with Takayasu disease, we will have our first speaker, that will be Professor Peter Villiger, in collaboration with Professor Frauke Forger. I don't know if I pronounce it correctly. Peter Villiger is currently Professor of Rheumatology and Clinical Immunology at the University of Bern, Switzerland, with long-lasting interest in vasculitis and important contributions to the field. Professor Villiger will focus on pregnancy in patients with Takayasu arteritis. Our second speaker will be Dr. Cahterine Sims. Dr. Cahterine Sims is a rheumatologist at the University of Duke, North Carolina, and also a research fellow at the Durham Veterans Affairs Hospital in North Carolina as well. She will be talking about pregnancy in vasculitis as well, but from a patient's perspective, from the perspective of a vasculitis pregnancy patient-powered research, underlying the important participations that patients may have in research. So, Professor Villiger, you can start. Sorry, at the end of the presentations, we will have a 10-minute question and answer period. So please write your questions to the chat, and from there will be addressed to the speakers. Thank you very much. And Professor Villiger, your turn. No, sorry, Heather.
Yeah, maybe first to give me the chance to switch to my presentation. Do you see the presentation?
So sorry, Peter, it was my fault. It's Heather.
Okay.
Time. Yeah.
Now is it better? Do you see something?
Yes.
Do I have to switch, or you see the presentation mode? Do you see the presentation mode?
No, not yet, Peter, but I think it's first Heather's turn to speak to the audience first, and we'll come back to you in 5 minutes, if that's okay. Yes, but keep it under your belt. Yes, thank you.
Hi, good morning, good afternoon, wherever you are. It's 3 a.m. here in California, so it's a bit early, but I'm always excited and happy to be at these things where I can kind of share, like, you know, a 5-minute spiel of, you know, the last 30 years of my life, I guess. I was diagnosed with Takayasu arteritis in 1997 at 13. I was one of the only patients at UCLA at the time, and so my parents navigated kind of what to do using, at the time, a message board for Takayasu's, because the internet was brand new, and being, you know, so rare, that was kind of how we got information and learned things. The big one being that Cytoxin came onto the table pretty early as something that they may need to use, and we thankfully were warned about the infertility side effects. And I got very lucky, and at the time was able to control my disease with methotrexate and prednisone, which has pretty much been my go-to for the last, I guess it's been almost 30 years at this point. You know, I always knew I wanted to be a mom, and so it was really important. And my parents, early on, my dad said that they did not want to make those decisions for me, which is why we would avoid Cytoxin if we could, but understood that if things got really bad, it was definitely an option. I was diagnosed with my initial aorta, was the initial diagnosis. I later had damage to my subclavian, so I lacked pulses in my left arm. The pulse returned in my right arm. And then in 2006, I had a pretty bad flare where I ended up with stents. So I have a subclavian stent and a stent in my carotid artery. Besides that, I'm doing really well, and I've been in remission for on and off for quite a while with no more extensive damage since about 2006. I knew that, we talked about having a baby, and in my 20s, the rheumatologist told me I would just need to go in and surprise my gynecologist because nobody was going to be that excited for me. And, it was possible. I knew other women who had babies. Thankfully, I had a different rheumatologist when I was in my 30s and ready to start thinking about getting pregnant after I got married. And we decided that we would go see high risk and talk to them before I decided to get pregnant, because I was definitely more of a planner and wanted to know kind of all of the risks and benefits and how they were going to be able to support me through that journey. They were less than excited to see me, and they had read my chart and basically told me that it was definitely not a great idea, that I would not be okay, the baby would not be okay, because I'd been on long-term steroids, which was news to me. They also asked if my arms worked because they'd read that I didn't have pulses. I left there. I was really discouraged and really sad. I talked to my rheumatologist, who said, she can't then tell me that it's fine for me to do it, but that, we needed to make our decisions for ourselves, that there's definitely risks, and she had successful pregnancies. And again, I had other women who had babies and they were perfectly fine. So I decided that I needed to clear it through my doctors, because clearly this doctor had only read my chart, which I didn't feel like gave me a fair chance of like who I was. I have extensive damage, I understand that, but at the same time, I work full time. I do everything that most people do, just at a little bit of a slower pace. I decided that the stroke risk was probably my biggest risk, and probably, after reading all the studies that I could get my hands on, seemed to be between a possible aneurysm and a stroke were the two things that I was most concerned about for my life, because I didn't want to leave my husband with, a baby, or without myself or a baby. So I decided to go to my vascular surgeon, who's the neurosurgeon, and I decided that if he would clear me, then we would proceed. And if not, then we would stop there and figure something else out. I went and talked to him. He said, I can't give you 2 big thumbs up, but he said, I'll get you through this. And he said, we can get you through this. And I said, good enough for me. I got pregnant about 6 months after trying, and went and saw high risk OB. And they, of course, were like, what do you mean we can't take your blood pressure in your arms? And I was like, sorry. And it's higher in my legs. And they're like, great, we're really stressed out about, possible hypertension as it is, and you're running high. I was in labor and delivery probably 20 times just to be seen and to check my blood pressure and to let my blood pressure relax. I ended up having to have a C-section they planned me at 37 weeks just because they had said they would prefer to get the baby out as soon as they could. That was safe for the baby. Perfectly fine. He was healthy. The C-section was a little bit crazy because people were on edge because my blood pressure is not that great in my legs and goes up and down. But the baby was fine. I was fine. No major issues. And I thought I was done with one. And a few years later, the vascular surgeon was like, you can have as many as you want. And I was like, well, maybe we'll try one more time. And so I have a second child. So I have 2 sons. That pregnancy was much easier because the OB was familiar with me and they were more comfortable. I had a planned C-section. He was early because, again, the blood pressure just is not, they did monitor in my arm. My pulse in my right arm has become better for them to monitor it. But even with that, I was just having a lot of issues with my blood pressure coming up and down. And so he was born at 36 and I think 3. Perfectly healthy, didn't need a NICU. I did really well. It was much easier because everybody was prepared for me that time. And I guess it was like a year before I was pregnant, I was invited to be part of the Vasculitis Pregnancy Research panel and as a patient advocate, and I absolutely love it. I was super excited to share my story and talk to the doctors and to try to kind of bridge the gap and the hole between, the doctors and the patients and kind of what goes on with the thought process and all the planning, and trying to help others to kind of avoid that first appointment that I had with a OB who was clearly not ready for me, but should be, because again, like I know plenty of women with vasculitis who have amazing, successful pregnancies and are great moms and have every kind of right to make those choices, and don't always get to make those choices due to the fact that like we're very scary on paper. And I've loved working with Dr. Sims and some of the other amazing doctors that I get to work with, and just being able to share my story and kind of, I think, make people a little more comfortable with the fact that like we're not perfect, but we can do this. And especially with kind of the help and the collaboration with the team of doctors, not just our rheumatologists, but all of our doctors and the high risk OBs, that like it's very possible to kind of, you know, have these pregnancies, even with all of the risks that might be involved, but at least giving these patients a choice to kind of make that choice given the risks, and to get more data around these, because we are here and we're having babies, and you know, like it's just kind of my passion in life at this point. And I have a 5-year-old and almost a 1-year-old, and I absolutely feel like they're just the biggest blessings ever, and I'm so thankful for rheumatologists that have supported me, and I'm just hoping to kind of give that back to other patients.
Thank you so much, Heather, for this moving story, which makes sense to all the research that is being doing. It is now Professor Villiger turn to talk about pregnancy in Takayasu from a more technical point of view.
So may I ask if you see the presentation mode?
Yes, we see it very clearly.
Okay. So hello, everyone. Thank you for having the opportunity to talk a bit about Takayasu arthritis, the disease first, and then our experience with pregnancy. As you see on the first slide, Frauke Förder and myself, we worked together for many years. She worked in research first, and then she took over heading the division of pregnancy and autoimmune diseases. She'll leave soon to become head of rheumatology at the hospital in St. Gallen. Our disclosures. And then Takayasu, as you know, very rare disease, kind of the small sister of the large brother giant cell arthritis. So the two diseases of different ages have a completely different incidence and prevalence. You see the incidence is very low. The ratio female-male is very high. So most of them are female. And very often it starts between the second and fourth decade. I've seen many patients even much younger. One started at the age of 8, and the diagnosis was delayed by many years. The only symptoms she had was that she couldn't concentrate in school, and one was thinking about social problem. And at the end, when we've seen that the CRP was elevated for a long time and nobody realized that. The infiltration, the inflammation is granulomatous, and it affects mainly the aorta and the large arteries, the primary branches. Here is a slide giving you an impression of the normal aorta on top, with the intima, the media, and the adventitia, the 3 layers. You see that the media has a lot of elastic fibers, which are very important in pregnancy, that you have an elastic membrane, elastic wall of the aorta. And on the lower panel, you see the inflammation, the thickening of the intima, and the inflammation in the media, which finally leads to scarring and to loss of elasticity. Key symptoms, according to the EURA recommendations, which we discussed in 2019, published then: new onset worsening clinical indication, then the constitutional symptoms, weight loss, myalgia, arthralgia, arthritis, and so forth. I don't list everything. I think the most important thing is that many patients, they start just with a limb claudication. One of my patients, she was swimming and suddenly was paralyzed in her right arm, and she had to be pulled out of the water. So that a very an attack kind of, but if you have lymph claudication, you know that the disease must be present for many years. So this patient certainly had a disease for 5, maybe 8 years. And I think this is the most important thing, because many of those don't have any constitutional symptoms. And for example, also in the findings, the carotidynia, which is listed on the bottom, if you ask the patients, they have pain in the carotids, but themselves, they hardly mention that. So it's a finding which you look for if you suspect the diagnosis. You see from our patient cohort the most prevalent attack of the aorta, the large arteries, and also the abdominal aorta. So it's you see that the left subclavian artery is most often involved. The arc is very often involved, and what is very important for the pregnancy is the abdominal aorta. I'll show you in this slide an example. So if we look at the aorta, the arc, and then the abdominal aorta, you see a severe stenosis of the abdominal aorta, and you also have the carotids. And as a second point, you see that there are collaterals, so you don't see any subclavia. And there were no symptoms. So the collaterals, they formed over many years. And you see that in this is in the Takayasu, you have very often a stenosis. So when the inflammation decreases, you have a fibrosis and the elasticity is lost. And this is mainly this slide summarizes the problem in pregnancy. As you know, the heart pumps the blood in the systole. The blood has to be taken up by the aorta, and based on the elasticity, the blood is pulled in the aorta and then gradually flows to the arteries. If you don't have this elasticity, the systolic pressure goes up and the diastolic goes down. So it's not only the high pressure, which is very often mentioned, but it's much more important that the difference between the systolic and the diastolic pressure. If this goes way up to 70 or 80 millimeter mercury, then there is a substantial risk of pregnancy complications. So in other words, it's very important if you plan a pregnancy that the heart and the arteries are assessed by an experienced person, and it's always important that you have a team of doctors taking care of you. From our cohort, you see the diagnostic delay. You see the years, minus 15 years, so 15 years, 17 years until the diagnosis was made. So you see on the right-hand side also that patients can become very old. On the top level, you have a patient which is now, I guess, 84, and she feels perfectly fine. The disease is inactive for many years. So you have a whole range of presentations of diseases, some of them needing for a long time an immune suppressive treatment, others can stop the treatment, many are without treatment and are very, very fine. But you have to control them because it can resume, the disease can reactivate at any time. So to summarize at this point, the Takayasu starts in women your fertile age, mean age in our cohort 32. It's a smoldering disease, as I tried to illustrate by the girl, which had certainly for a long time had the disease. It was not realized, not recognized. It's a smoldering disease, very often subclinical, developing and destroying the wall of the arteries. We have non-specific symptoms, which makes this very difficult in young people. The diagnosis, as I said, very often delayed. The treatment was glucocorticoids and DMARDs, but nowadays most of the patients, at least in our hands, are on TNF blocking agents and on anti-IL-6. And you know, TNF blockers are pregnancy compatible, so we switched sometimes also patients from anti-IL-6 to anti-TNF if a pregnancy was planned. Steroids I use rarely. I try to avoid those, and for DMARDs, the regular ones, methotrexate, azathioprine, and so forth. And the damage, arterial hypertension, the stenosis, as I mentioned, and as I mentioned also the stiffening of the aortic wall, which is very important. Now, interaction Takayasu pregnancy. The physical adaptive cardiovascular changes in pregnancy. You have an increase in circular blood volume. You have an increased cardiac output, which all means stress for the aorta. And you have, in addition to that, the compression of the abdominal aorta by the gravid uterus. And then have here hormones which help dilate the aorta and improve the architecture in order to have the elasticity. And if it's a fibrosis and if it's a severe stenosis, obviously the hormones cannot do that effect on the aortic wall. So the presentation of our cohort, we have now, in addition to Bern, St. Gallen, Lucerne, Basel, and Lausanne, participating in this multi-center study. These are preliminary results. So we have a preconception counseling only in a third of patients. That's not really convincing, but we now formed the Vasculitis Association Switzerland, and we believe that we can improve that people know and find information much easier, and that the diagnosis is made much earlier. Pregnancy outcomes of 34 women, 51 pregnancies of 22 patients. So live birth in 71%, miscarriage in 29%, preterm 8%, and low birth weight 11%. And in maternal health issues, you see the preeclampsia and then the arterial hypertension and new onset arterial hypertension. So you see in maternal health issue, obviously cardiovascular system is very important, and it all goes back to the aortic wall and the changes in the elasticity of the aorta and the large vessels. Active TAC during pregnancy only 25%. Now, you are certainly interested how the disease changes during pregnancy. And we have in the 51 patients or 51 pregnancies, we have 40 with inactive disease at the beginning. Then there are some patients becoming active during disease, and it normalizes after the disease. So only a small proportion of patients get active or got active in our cohort. If you look at the literature, this review of 505 pregnancies in 373 TAC patients, you see that live births in 84 on the pregnancy infant side, and the maternal side, again, I repeat, hypertension, eclampsia, and cardiovascular complications. Interesting, from the same cohort, adverse pregnancy outcome. If the pregnancy took place before TAC diagnosis, the risk was 6%, and after it went up to 40%. And most likely, also the 6%, they had already signs of the Takayasu arthritis, which were not recognized, but were not important, because obviously the disease was not advanced at the stage of the pregnancy. To the question TAC disease activity and its effect on adverse pregnancy, there are the French cohort with 98 pregnancies, indicating an increased risk. So the cumulative incidence in inactive Takayasu, the bottom line is the steady increase, and in the active disease, the line goes up around week 20. So when the cardiovascular problems come into play. And no was proposed by the Norwegian TAC cohort, 24 pregnancies, and the French cohort, 43 pregnancies, where they didn't see any effect. So which factors are associated with outcome in TAC pregnancy? To summarize, question mark, active TAC, pro and con, certainly intradiaphragmatic vasculitis, certainly arterial hypertension, Obviously also smoking. I don't have own data about that because most patients don't smoke. And delay in medical care. If I summarize pregnancy in Takayasu, we have the risk factors for maternal morbidity, which is hypertension, preeclampsia, and vascular complications. The risk of adverse pregnancy outcomes, the insufficiency of the placenta and preterm birth, and there's a low risk of disease flare during pregnancy. In my personal experience, I had one patient, she has now 3 children. She had very severe disease at the beginning, but the scarring of the aorta was not advanced, so there was really active inflammation, and we had big problems in between of the pregnancies. But now she's, for many years, she's in stable remission on very low dose of infliximab, azathioprine, and 3 milligrams of prednisone. She wouldn't need the 3 milligrams of prednisone, but she is much afraid to stop treatment. So in conclusion, I'm very positive about pregnancy during if you suffer from Takayasu arthritis, but it's very important to have a good team with a lot of experience and to counsel and to guide a person through pregnancy. So that's what I wanted to tell you. Thank you.
Thank you very much. We will have the questions at the end of the sessions altogether. And now is Dr. Cahterine Sims will start her presentation.
Okay, Colleen, does that look okay?
Yes, looks fine to me. Yeah.
Okay, great, thank you. Yes, hi everyone. My name is Cahterine Sims. I'm a rheumatologist who focuses on women's health and reproductive health. And so I've been working with the Vasculitis Pregnancy Registry, or VPREG, since 2000. Heather and I have worked very closely together. And I'm going to present today some of the results of 2 studies that we are publishing this year. They've already been accepted and will hopefully formally come out in a couple of months. But kind of just going after Dr. Villiger's excellent presentation, there's limited data on vasculitis in pregnancy. And this can make it very difficult for patients to decide if they want to move forward with pregnancy. This can be a very scary time for them. It's uncharted territory. You know, we have some data, but it's really not robust enough for us to have expert clinical guidelines. So it's truly a case-by-case basis. And what we've learned from other rheumatic diseases like lupus is that when women plan their pregnancies during times of well-controlled disease on pregnancy-compatible medications, and they continue those medications during pregnancy, that increases their chances of having a successful pregnancy, which we define as a healthy mom and a healthy baby. And so VPREG was created by 2 of my mentors, Dr. Peter Merkel and Dr. Megan Close, back in 2015, in order to answer the questions, do women with vasculitis flare during pregnancy? And what are their experiences with pregnancy and what kind of outcomes are they having? So just to give you an idea of what VPREG looks like, because we get a lot of questions about the workflow and methodology. Any woman who is pregnant with vasculitis can enroll. Your doctors do not have to enroll you. And you enroll yourself, you do a baseline survey, and then you answer a survey each trimester, and then 1 survey after you deliver. And the surveys cover a lot of different information. So at baseline, we're interested in what kind of vasculitis do you have, what's your disease manifestation. So like Heather was saying, you know, she has aortic involvement, subclavian involvement. We're very interested their journey with their vasculitis, what kind of medications they've been on, and also what their pregnancy history is. So do you have a history of any miscarriages? How far into your current pregnancy are you? And that helps us to get an understanding of the demographics of women who are enrolling in VPREG. Now, in each trimester survey, we're interested in how are you doing from a wellness and a physical health perspective. Is your disease flaring? Are you requiring hospitalization? And then also, how is your pregnancy going? So are you having any abnormal ultrasound results, abnormal labs? Have you lost the pregnancy? And what kind of complications could you potentially be experiencing throughout the different trimesters? And then the postpartum, we're interested if you're flaring after you deliver, if you're attempting to breastfeed, what medications you're taking, and if they've changed since your pregnancy. And then what was your delivery experience like? So did you have a cesarean or a vaginal delivery? Did you require induction? And how is your baby doing overall? So currently our VPREG surveys are available in 5 different languages. The results that we are publishing this year are from 78 pregnancies in 76 women. These women were mostly in their early 30s, and we had 11 countries and 5 continents represented. Now, North America is where the majority of our patients have enrolled from, and we are working a lot, very tirelessly, to improve our international recruitment. And that is one of our short-term goals over the next couple of years in order to enroll more people from different countries. We're translating more of our surveys in order to serve a broader population. Now, this is the breakdown of the types of vasculitis that were represented in our 78 pregnancies. So small vessel was overwhelmingly the most common, with ANCA vasculitis being the most common within that category. This was followed by Takayasu, or large vessel vasculitis, and then Behçet's disease, or variable vessel vasculitis. In each of these slides, you'll see kind of a summary statement at the bottom. So most women had small vessel vasculitis, and they were located in North America. What kind of medications were women taking during pregnancy? So first, what's important to note is that the majority of patients were prescribed some medication for their vasculitis during pregnancy. And I find this an important point when I'm talking to patients about pursuing pregnancy. They don't have to get off of all their medications. In fact, we don't want that. We just want to ensure that they've transitioned to a pregnancy compatible regimen. Now, what was interesting is that nearly half of the women in our cohort were prescribed glucocorticoids. This is bothersome or concerning because what we know is from asthma data that women who are on higher doses of steroids like prednisone for a longer period of time throughout pregnancy are higher risk for things like preterm delivery. And also there's side effects of gestational hypertension and gestational diabetes. So I'm curious, and we don't know why these women were on glucocorticoids. So potentially their disease was flaring. Maybe their rheumatologist just felt comfortable with prednisone as opposed to another vasculitis medication. Or maybe these women just struggled to get off of prednisone, kind of like Dr. Villiger was saying, he has that patient who's on 3 milligrams of prednisone. And sometimes we continue patients on those in pregnancy because it's difficult for them to get off, either their disease flares or the patient just feels very dependent on that lower dose of prednisone. So it's always a risk-benefit discussion with the patient. Azathioprine was the most common, what we call a DMARD medication, followed by biologics, which was a TNF inhibitors were the second most common. Now, something else that we looked at are prophylactic medications. So aspirin, either 81 milligrams to 162 milligrams daily, starting after the first trimester, in the US is recommended for women who have lupus or antiphospholipid syndrome. And so we've, in our clinical practice, have extrapolated that to women with vasculitis because, as Dr. Villiger showed with his data, as we'll show with our data, preeclampsia is certainly a high risk condition that we see more frequently in women who have autoimmune diseases. And women with vasculitis can have low-grade chronic inflammation that could potentially contribute to that risk of preeclampsia. Now, what we saw is less than a quarter of patients were taking a baby aspirin or any type of aspirin during pregnancy. And this could be because there really aren't any expert guidelines for women with vasculitis. We are simply extrapolating from other autoimmune diseases, which may or may not be the correct decision for women with vasculitis. But the way that we viewed it is it's a very low risk, high reward intervention. We also wanted to know how women were doing from a wellness perspective. So what we asked is, considering your vasculitis, considering your pregnancy, how would you rate your wellness? And then we asked the same question with pain. Now, just to make things more confusing, a lower score of wellness was better and a lower score of pain was better. So both lower scores are the direction we want to be moving in. And most women reported that their wellness and pain were on the lower end of the scale. Now, when we asked about functionality, these are the different questions we would ask, and the percentages are women who reported that that task was difficult for them. Now, as you can imagine, when you're in your 3rd trimester of pregnancy, walking 2 miles is going to be difficult just because of the physiologic changes of pregnancy. You have an expanded blood volume, Your diaphragm can be pushed up because your uterus is growing. I mean, there's a lot of physiologic and anatomic shifts that occur that make daily tasks difficult. So we wanted to make sure that the functionality limitations were truly due to vasculitis and not just due to being pregnant. And when we compared these percentages to women who were pregnant without vasculitis, we found very similar percentages, meaning that likely these difficulties that women were reporting are a result of the pregnancy itself and expected limitations just from being pregnant, as opposed to the vasculitis causing them increased issues with their functionality. So that was very encouraging to us, because women asked me, you know, how am I going to do during pregnancy? You know, am I going to be bedbound? Am I not going to be able to do daily tasks? I have other children. Am I going to be able to care for them? And from the data that we have, most women are able to preserve their functionality independent of the vasculitis, and they may have some functional limitations due to the pregnancy itself. Now, about a third of women reported vasculitis activity during pregnancy. This isn't too surprising. We see this in rheumatoid arthritis as well. About a third of women will have a rheumatoid arthritis flare. So not too unexpected. Now, I will say that we gave patients freedom to define what a flare was. So one woman may say, well, I had increased sinusitis because I have encapsulatis, whereas another woman could say, I have Takayasu and I have active aortitis. So that spectrum was very broad on how they defined active disease. Most women did not have ultrasound abnormalities, but of those that reported abnormalities, I have them listed here. There's only 2 instances where this impacted the final outcome of the pregnancy. So the first was a patient who experienced a fetal demise at 22 weeks of pregnancy. And the second was a twin demise at 14 weeks. So one of the 2 twins had died in utero. Otherwise, although there were abnormalities that were reported, they ultimately resulted in a live pregnancy. Now, I will say the patient who experienced the fetal demise at 22 weeks, she went on to become pregnant again and delivered a healthy baby. The woman who had the twin demise, she delivered the other twin who went on to be very healthy, and it was a live birth. So while that was a discouraging moment in their reproductive journey, they ultimately both experienced live births following those events. Now, most women experience live births at term, and they delivered vaginally. And this is certainly how we would define a successful pregnancy. The only 2 that did not result in a live birth were the fetal demise I just mentioned, and then somebody, one of the patients underwent a therapeutic abortion for medical purposes at 5 weeks, with the mean gestational age or median gestational age around 38 weeks. So most women are carrying to term, which is great. As Heather mentioned in her story, most women are induced or they deliver around 37 weeks because the doctors really just want to get the baby out as soon as possible at the safest moment to prevent the risk of developing preeclampsia. Now, as you'll notice, 25% of our patients developed preeclampsia, and this is around the rate that we see lupus nephritis patients developing preeclampsia. Now, the pathophysiology of preeclampsia is unknown in and of itself. There's a lot of hypotheses, and we certainly have some insight, but we think it's a issue with the placental insertion into the uterus, and so that maternal fetal interface has some type of abnormality that then is driving the preeclampsia. And so if you think of vasculitis causing inflammation of blood vessels, potentially vasculitis could impact spiral arteries or other ways that the placenta is perfused that could then potentially impact the risk of developing preeclampsia. And that is a very oversimplified hypothesis, but we're trying to understand, just like we're trying to understand why women with lupus nephritis go on to develop preeclampsia, we're also seeing that increased signal in women with vasculitis. Now, most children were reported to be healthy. The women who reported their children to not be healthy, I have listed here for a various amount of reasons. And again, we left it up to the mother to define what healthy and not healthy was, and we saw quite a spectrum. Most women attempted breastfeeding, and as you'll see here, some women went on to breastfeed for longer than a year. Now, the next study we're publishing is a qualitative study. So I interviewed 18 women with vasculitis to ask them about their journey through pregnancy as a patient with vasculitis. So after women completed their surveys, I then contacted them and requested if they would be interested in an interview. And really what we're asking is, what was it like having these conversations with your healthcare providers? How was your disease during pregnancy? How did you decide which medications to take? What resources were you using to inform those decisions? And then ultimately, what was your delivery experience like? So there are 4 different themes that we picked up on. So the first theme is that women are seeking information on pregnancy and breastfeeding from a range of sources, and this is likely due to the lack of robust data in the medical literature. So most patients really focused on their relationship with their doctor, and in this case, it was the doctor managing their vasculitis. So that may be a rheumatologist, it could also be a nephrologist or a cardiologist. And so they really sought the approval and support of their doctor, and many of them felt that their doctors were supportive. All the women said that they did use online resources, and this could be social media or online forums, but they actually all denied that it ultimately impacted what they decided to do. So you can see that women are going to medical professionals, but they're also going online to see what kind of information is out there. They can also talk to other women in forums and ask questions. And for some women, they find that to be very helpful and informative. I have a few quotes that I will pepper throughout the rest of the slides, but this patient is talking about the isolation of having a rare disease, and I wouldn't be surprised if that drives some of this initiative to be a part of these online communities where you can meet people who understand you more than your doctors, or sometimes more than your family, just because they're living the same journey as you are because they have a very similar condition. And then some people found that the online resources were triggering for them. So one woman described feeling guilty because there were people in the online forum who were sicker than her. And sometimes it would provoke anxiety because people thought, well, that could be me in the future. And so for some people, the online forums were not a source of comfort or community. But then other people said, well, I found a ton of friends on online communities, and I meet up with them at conferences, and they've become a second family to me because they really understand what I'm going through. The second theme is most patients had positive reproductive experiences, and I define that as they had a live birth and baby was healthy and mom was healthy. And so women talked about these milestones in their reproductive journey, being concerned about being fertile and being able to conceive because they had taken cyclophosphamide in the past to control their disease. Another woman described the differences between her physical health and her mental health. So she's like, I physically did well, but mentally it was a big struggle for me. And I do wonder if just the threat of the vasculitis flaring or impacting the pregnancy caused a source of anxiety for patients. And then the last was their induction and delivery process. And most women were actually surprised at how well their delivery went. Now, there were some women who did have experiences of some side effects from the spinal anesthesia, but nothing that we wouldn't expect in the general population. The third theme is that women are having discussions with their family members and their doctors when making decisions about medications during pregnancy. So I have 3 different scenarios here that are listed, each around different medications. But as you can see, a lot of decisions are structured around the vasculitis medications. So this woman is planning her conception time around her rituximab infusion. Another patient is getting off of methotrexate before attempting conception, which is absolutely the correct thing to do. And then another patient is discussing continuation of azathioprine through pregnancy in her discussions with high-risk obstetricians and her rheumatologist. So vasculitis in and of itself is certainly a factor that influences women's decisions, but medications as well are impacting the timing of their pregnancy. And this is the last theme. These women have a lot of self-advocacy, and I don't know if that develops in pregnancy, if it's highlighted in pregnancy, or if they've developed this before they become pregnant. But a lot of them describe doctors not wanting to take responsibility for them in pregnancy. And really what we see is primary care, rheumatology, and obstetrics. Everybody's uncomfortable. Everybody knows that there's limited data in this space. And it's going to take time and effort to collaborate with the patient, collaborate with other specialists in order to make decisions that are right for that patient. Patients pick up on that, and they also sometimes absorb that burden by becoming the go-between of all these different doctors. And on top of having a chronic condition, on top of making the decision of pregnancy and becoming pregnant and taking medications during pregnancy, they also become their own medical liaison between different physicians. As you can imagine, the mental burden that takes, that toll that it takes on the patient is not ideal. And many women described this, and this has also been described in the inflammatory bowel literature. So it's not just autoimmune diseases in rheumatology. My last slide is that VPREG is a huge network. If you're a provider, please send your patients our way. If you're a patient, please enroll yourself if you're pregnant. We're a big community. Research is just one aspect of that. So thank you.
Thank you. Thank you very much. It is now the turn for questions and answers. Please write your questions in the chat. For the moment, there are no questions in the chat, so let me start with one question. I have a question for Professor Villiger. Dr. Sims mentioned a low rate of therapeutic abortion in her series. So what's your experience in Switzerland? You have what's your rate of therapeutic abortion, and if there is any gender difference among physicians counseling therapeutic abortion or not? So the question may be for the both of you. Yeah.
Can you repeat the last? I didn't get the second part of the question.
The first part of the question is in your review of the literature or in your personal experience in VAS, as if you, how was the rate of therapeutic abortion?
I cannot give you a figure, but I think it's not higher, not much higher as compared to other populations.
And my question to Cahterine, did you see any gender perspective or differences among physicians counseling abortion or physicians not counseling abortion?
That's a really great question. And I will say that we likely are missing a lot of abortions because we are only enrolling pregnant women and we're not capturing that pre-pregnancy phase. And we're probably missing a lot of first trimester miscarriages as well. We did not discuss abortion in my qualitative interviews, but I will tell you that when I go to conferences and I give talks, I have had male doctors come up to me and say, I just cannot discuss pregnancy the same way that a female physician can. And I truly believe that that interface with patients is very different. He said that he felt paternalistic for even bringing up the topic of abortion, which I thought was really fascinating. And so I do feel like there are gender differences. I've been interviewing some providers on the VA side at a different hospital, and I have noticed that the female doctors are much more comprehensive in their reproductive conversations. So their first question is, do you want to continue this pregnancy, as opposed to walking into the room and saying, congratulations, you're pregnant. So I do feel like female providers are probably a little bit more aware of the consequences of a pregnancy, of the emotional and physical burden of being pregnant, more so than male providers. And that's just anecdotal, that's just my own experience, but I haven't professionally or in a research way asked those questions.
Thank you. We know that infliximab and rituximab may be relatively safe during pregnancy. Do any of you have some experience with patients accidentally if any patient accidentally got pregnant with while receiving tocilizumab?
I'm not aware of a patient in our cohort, but most likely there are patients, because the data of infliximab we have mainly from patients with a IBD who didn't tell the doctor that they are pregnant, they just went on, and so we got a lot of data of those patients, of that patient group.
I am asking that because tocilizumab is gaining a lot of acceptance among physicians treating patients with Takayasu disease. I have also a question for Heather. Probably during your first pregnancy, you probably had some anxiety. You probably were reinforcing your decisions, but probably you had to face a lot of uncertainties. So in this regard, was your second pregnancy more confident based on the experience you had in the previous one?
Yeah, so the first pregnancy I did, and that's my blood pressure problem. My blood pressure is what we call white coat syndrome. So the anxiety of the unknown, right? Like I've dealt with my Takayasu's for 30 years. I know my disease. I know what my body does. I know how to watch it, but I bring in a baby and I'm like, this is where I need help because I need you to guide me and tell me. I need my OB to tell me. And when I would go in with a blood pressure that in my leg was much higher than the nurses were used to, alarm bells would go off. And I was very lucky to have a team of doctors at my hospital that the OBs could call and be like, it's okay, she's okay. And I had to usually tell them, I'm like, I'm not here because I'm concerned that something's wrong. I'm here to let my blood pressure calm down and to let you guys calm down so you guys know that we're okay. And then you can let me go home until I come back in another week. And it was the same way. I spent, I want to say, a week or two in the hospital both times before the babies were born. And that was often just because it made them feel better and it made me feel better. There was really nothing that happened or that went wrong. But because I was such a high risk for preeclampsia and they were so careful and they had such trouble kind of watching it, I just preferred to be there. They preferred me to be there. But the second pregnancy, I think my OB was less excited about the blood pressure fluctuations. I still ended up in labor and delivery out of caution, and that was okay and just something we all accepted. But I did have a better time with my C-section. The first one, they had attempted to vaginally deliver, and my baby just was too big. His head was too big, and he was stuck. And so it was not an emergency at the time, but it could have been an emergency. And that team was not necessarily prepared for me. And so in the OR, there was a lot of anxiety from them with my blood pressure. They dumped it at one point because they were too excited about the anxiety coming up and down. The second time I really got my anesthesiology team on board, and I had an anesthesiologist who took a lot of like interest in my case and how Takayasu's might be affecting my blood pressure and my anxiety. And he was able to control my blood pressure in the OR setting, which made everything much easier. I didn't have to go to the ICU after because they were afraid of things. So yeah, I do think that, you know, everybody was a little more at ease with me the second time around, but I still had a lot of anxiety because there's still a lot of unknown. But again, yeah, the second time was easier, and I think it was easier for the team to work together. And there's always that, well, she did it once, so like we can do it again. But there were a lot of things that I think I learned that I've been able to share, like with Dr. Sims and the other doctors, that would have made things much easier the first time around. And I think the biggest one being that the collaboration, and like she's saying, I'm the one who has to do all of that. I have to go to this team and go to that team. And the second time, I think my OB kind of knew who I needed to check in, whereas before it was like, well, do you go to your vascular surgeon? Did you see the cardiologist? And I think, again, being that I've been doing this for 30 years, I know who I need to go to and be like, okay, they're concerned with this. I would rather go and have like my cardiologist listen to my heart and look at my heart, as opposed to be in an emergency setting and they're like, well, what happened? So I did pre-checks all along the way, even though my doctor's like, we'll see you in a year. I was like, you will see me in 3 months. So I think that, you know, collaborating was just easier, and I knew where I needed to go, who I needed to go with, and what could possibly happen. But I think a lot of it is the doctors too, right? You can tell when you walk in that they're anxious. As good as doctors try to hide it and try to be like, we've got this, everything's fine, you could always tell there was panic in the room. There's a crash cart. There's a lot of different people. And again, because I was at a big teaching hospital, all of my doctors are there, and my cardiologist usually was on call, and so they're panicking because I also have a very high resting heart rate. And you add pregnancy and anxiety, and my heart rate was extremely high, and they're always worried about a stroke because of everything that's damaged from here up. And so having my cardiologist be able to just talk to them through it and just be like, she's okay, do not give her blood pressure medications because you'll dump her blood pressure. It was easier because the first time around, I didn't know that. And they did dump my blood pressure at least once in labor and delivery, because again, I'm there trusting them to do what they need to do. And unfortunately, I'm not a regular patient. So my blood pressure is high. You need to give me a second to bring it back down, as opposed to somebody whose blood pressure is high and it's an emergency. So yeah, it is easier the second time around for everybody involved, I think.
So I think that reinforces the concept that Dr. Sims point out, that sharing experiences is very important. In your case, you shared the experience with yourself, but it's so important to share experiences with others. I don't know if this cannot be deduced or concluded from the data you have, Professor Villiger and Dr. Sims, but maybe by talking to OB obstetricians, you or by yourselves, do you have an estimate of how many women with Takayuki or with other types of vasculitis refuse pregnancy when, you know, made aware of the potential risks?
So women who decide not to move forward with pregnancy because of the vasculitis risk. Yeah, I mean, so we see at our one institution not a ton of vasculitis pregnancies, I think, which is why Dr. Merkel and Dr. Close created an international registry. I have had patients and women who have chosen not to move forward with pregnancy. It's typically multiple conversations with them. So for example, I did have a Takayasu patient last year who showed up who had a very large thoracic aortic aneurysm. And when I had her see high-risk OB at my institution, we then met and discussed together before going back to the patient. And we felt that the risk of a rupture or dissection was so high that we recommended against pregnancy. And that patient went on to use surrogacy in order to fulfill her reproductive health goals. So I have had patients choose that route, especially also those with lupus, maybe who have chronic kidney disease. But typically, it's after multiple conversations, weighing risks and benefits, and they ultimately choose another route that's the safest for them, but they can still achieve their personal goals.
I think
yeah.
you have to always go for a risk assessment by the cardiologist. The problem is that the cardiologists don't know the disease themselves. So for many of them, it's difficult to really make a risk assessment. And I have a tendency to support patients and at least to discuss it several times and to at least having an experienced cardiologist judge the situation, which is easy in a small country.
So if there are not no more questions, it's time to close this session. And I close this session by thanking the speakers very much and the attendance. And thank you very much again. And we will continue the webinars sometime. So thank you.
Okay.
Thank you.
Thank you.
Bye. Thank you.